All right, so let's go ahead and get started here. So we were leaving off, we talked about the different types of hepatitis. So we have some management for A and B. C is going to be the last one we'll talk about here. This one used to be something where we didn't have really good treatments for it, and it was kind of a lifelong condition people dealt with. Nowadays, we do have some curative treatment, which is pretty revolutionary. It's also nice because a lot of the therapies that we're using before were all like injectable products. They're really expensive. Nowadays we have ones that are oral, which is nice. Pretty defined treatment time. They're still pretty expensive, but if you kind of consider the cost of something like a liver transplant versus having to have this expensive medications, which I'll tell you what the cost is in just a little bit, you'll see that it definitely weighs in the benefits of the medications for sure. Anyway, so what we're going to try to do is, again, get a virologic cure, try to wipe out the virus entirely, so you want that sustained sort of virologic response there, and try to prevent any kind of end-stage liver complications, liver disease, or need for transplant in those cases there. Typically, you have to do baseline treatment because there are different subtypes of hepatitis C, and so we want to make sure you know which one you're dealing with, because you'll find that different strains will respond differently to the medications, and you'll find that some medications are only good for certain subtypes, which I'm not going to get that granular on the test and ask you specifically, but you should at least know that there's a difference there. So before, we used to use interferon. You guys remember any issues with using interferon? Anaphylaxis is a risk for sure. What else? Remember, it's stimulating your immune system, so it really just made you feel miserable. It had a lot of like flu-like symptoms associated with it. It could worsen depression, cause suicidality. A lot of issues with it from that standpoint. So nowadays we've been able to get away from that, and we only use it for really difficult to treat cases or cases of severe resistance. As I mentioned, there's different subtypes here. So there's like GT1 through 6, and there's even subtypes of that. So for instance, like GT1A and B are the most common here in the US, but if you were to go out of the US, you might find other subtypes more commonly. And the treatment time is typically between 12 and 24 weeks. So really between 3 and 6 months, and then boom, you're cured of hepatitis C, which is pretty cool. So the reason why we can do that now is because we have what we call the direct acting antivirals, the DAAs. And so essentially there's a couple different targets here we can be shooting for. So we can do things like inhibit the actual proteins that are responsible for producing the proteins from the viral RNA. We can do things like prevent the maturation of the proteins to prevent them from ever forming a fully formed hepatitis C virus. And so frequently you'll find that you're using these in combination as well in order to make sure you're getting some synergy in terms of those mechanisms. I will tell you that these are probably the most difficult to say drug names in terms of just like awkward syllables that are put together. So like daclatasvir, it doesn't really roll off the tongue that well, but Declenza does certainly, so if you can just call it by that. But just as an example of the different subtypes and what it might have activity against, for instance, this one is for GT1 and 3. Now I'm not going to ask you when I test a patient has GT type 2, which one of these is appropriate. No, but I want you to know that there is a difference there, and you might use one medication for one type of patient and a totally another drug for a different type of patient, depending on that subtype. So anyway, what this one is doing is basically prevents the RNA replication and the assembly of the virion basically by binding to this NS5A protein that will basically cause a distortion of the protein structure such that it cannot interact with the viral RNA anymore, and so thus you're not going to be able to produce any new RNA. Okay. So prevent that process. And the nice thing as well is that there's really mild side effects. There's not a big issue in terms of liver or renal dysfunction you have to adjust for. However, it is quite expensive. So about $20,000 a month. And again, if you're thinking between 12 and 24 weeks, pretty expensive. But again, the cost of having someone have a sustained virologic cure versus needing a liver transplant down the road, it definitely weighs in favor of the medications here. But just to give you an idea. So in terms of that, you have to think about things like insurance coverage. You have to think about, are the patients going to actually be able to stick with the medication, getting it from month to month? Because what's the issue if, say, they get the first month's worth and then they don't follow up? What happens like an antibiotic if you don't take the full course? Resistance, and the same thing can happen here. So you want to make sure, and just like with like HIV, you want to make sure they're definitely going to be taking the full regimen, because if you get a resistant subtype, then all of a sudden drugs like this might not work anymore, and so that's going to be a problem. You actually have a combination drug here called ledipasvir and sofosbuvir. This one, again, has pretty wide-ranging activity against 1, 4, 5, and 6. Here you're finding some synergism between mechanisms where the ledipasvir works on the NS5A, just like the dacladosvir we saw in the last slide. And then sofosbuvir is actually going to be working as a nucleotide prodrug that will prevent another protein, it's NS5B RNA polymerase. So it's actually directly inhibiting the polymerase, preventing that new RNA from being formed there. It's kind of like a chain terminator, very similar to the NRTIs that we saw on for HIV, right? So things like abacavir and things like that are basically working on those chain terminators. You may find this one used by itself for other types of regimens, but again, these all are going to be expensive in and of themselves. Again, this is nice, no dose adjustment, very mild side effects, but again, quite expensive. Semprevir or Licio is going to be, again, working at another site. So this is the NS3/4A protease inhibitor. Basically, this is going to be the target where the proteins for the virus is made, but it's in big one long chain. And so by inhibiting this enzyme, you prevent it from being chopped up and being turned into sort of mature proteins at that point. Again, you'll find that this is typically used in combination with other agents to get some synergy there, using it not as monotherapy, but again, it's sort of a backbone there. Again, pretty mild side effects. Here, for instance, though, you can use it in a combination with things like sofosbuvir or like interferon and ribavirin therapy. We haven't talked about ribavirin too much, I don't think. We did mention interferon for sure. That was the old way we used to treat it. It was a combination of interferon and ribavirin. You'll see that nowadays these are going to be reserved for patients that have like really resistant strains of Hep C, or maybe if patients are not responding well, which is the normal regimens, you can add this on potentially. Betacvir is another NS5A protein inhibitor, and so this is again another one that's given in combination with things like paritaprevir or even ritonavir in some cases. Ritonavir, what does that do for us? And it's that potent CYP3A4 inhibitor, right? So it works as a booster, and you can see here's another case. Now again, do patients with Hep C ever have HIV concomitantly? Yeah, quite frequently, right? So you're going to find that it could be nice you're getting additional boosting from that. Or for instance, if they were on something like, Kalitro, which is lopinavir, ritonavir, maybe you don't need to add that additional ritonavir if they're on a regimen like this. So just to give you some examples of how we might have to mix and match. And again, you can see how the medication regimens for these patients can get out of hand pretty quickly in terms of just the number of them. So ribavirin here we'll talk about, we don't know really the full mechanism. We think that maybe it has something to do with causing a lot of mutations in the viral RNA, such that it leads to this like error catastrophe. Some people call my lectures the same name, but basically it causes so much damage to the RNA that it just says, no, we're done, just triggers off apoptosis and says, no, we're not going to continue on. It also thinks to be somewhat immunostimulatory as well, kind of similar to the interferon from that standpoint. Again, this was used in combination with interferon as sort of like the gold standard of therapy, but it wasn't great. It suppressed the virus, but it didn't really cure it. And so you'll find a ton of side effects associated with this, some of which are similar to what we saw with the interferon, things like suicidal ideation, depression, all of that. So you definitely want to be careful with that. Black box warning for those. And you can even get things like hemolytic anemias in about 10% of your patients, right? So that's 1 in 10 Hep C patients you're treating was not great. And also it's going to be pregnancy category X, and they actually recommend even female patients of childbearing potential use 2 forms of contraception for even 6 months after discontinuation, right? Because again, you can find detectable levels in the blood for up to that long. It's still affect a fetus. So again, something you want to be cautious with. And again, this is still used occasionally, but typically it's for the more resistant subtypes of the virus, or maybe if you have a patient who's already developed cirrhosis, this might be something you'd want to add on for those regimens. And I'll give you a slide that will show you what some of those combinations look like in a little bit later. As I mentioned with the ribavirin, they're typically not used unless you have maybe some prior treatment resistance or underlying cirrhosis. Peg interferon, which is just a pegylated form of the interferon we talked about before. That use has definitely gone down substantially, which is great because it's a really terrible drug in terms of side effects. And then for patients that do have cirrhosis, because again, you may not catch this really early on, maybe more developed when they actually are having hepatic complications, it can be more difficult to get a good sustained virologic response out of this, in which case here, we may need to adjust that a little bit. So most of the time those drugs don't have to be dose adjusted, but in those cases here where they have really severe liver dysfunction, you may have to consider that. And then adding on things like ritonavir or ribavirin, I should say, in order to help make sure you get that good sustained response. For patients who have treatment experience, I mean, maybe they've been on interferon and ribavirin before, you may want to consider treating them for the longer course. So maybe instead of 12 weeks, you do the 24 weeks to make sure you get that good sustained response. And you may even consider doing things like resistance testing, kind of similar to what we saw with the HIV previously. What's interesting with that, and again, like with HIV, like when do you start treatment for those patients? Start immediately, right? For this one, you may be able to hold off a little bit, especially if you catch it early on. You may be able to wait, say, 6 months or so and determine if patients are going to clear it on their own. There's about a 50% clearance rate for those patients there. So you can defer therapy in some cases, kind of similar to what we saw with like the HBV, where you can maybe hold off on treating until you start to see something in terms of like, either viral load or, the LT start to go up. This is similar where you can see if they clear it or not, and if they don't, then you can start treatment at that point. Because again, if they don't need it, then that saves them quite a bit of money in the long run. Again, compliance has to be ensured. If they're going to be on it for a 12-week regimen, you have to make sure they're getting every single month of that drug, because we don't want to have resistance to these and then lose the efficacy of these drugs. So just to give you some examples of what this looks like, depending on the subtype you're dealing with, you may choose different regimens here. So for instance, you could do things like if you have 1A or 1B, which is pretty common in the US, you may do decladisvir plus sofosbuvir for just 12 weeks. If they do have things like underlying cirrhosis or resistance, this is where you can consider adding on things like ribavirin and then doing for longer treatment times. So it's kind of the difference you'll see between those. And again, don't get so hung up on this slide in terms of like what are acceptable regimens. I would just, again, know the mechanisms of the drugs, kind of know what they're used for. So you can say, okay, a patient diagnosed with Hep C, which one of these would be an appropriate drug for them to use? Things like that I want you to kind of key in on, okay? Any questions on that section? No. Let's continue. I think we have peds and geriatrics next. Is that correct? I hope so, because that's what I'm doing next. Is anyone worried about the coronavirus? No. Everyone washing their hands for a good 20 seconds? Whenever I see students in the bathroom, I say, was that 20 seconds? And then they go back and they do it again. It's the problem with sharing bathrooms with students. I went to Starbucks the other day, and the barista had a face mask on, and I was like, oh, are you really worried about the coronavirus? And she said, no, it's really just a coffee filter. Anyway. So let's start with pediatrics. This will be sort of a recap of what we went over back in the intro to Pharm back in the summertime. The difference is now we know a whole lot more about drugs than we did back then, and so we can kind of think about this from a clinical concept or context and how we're going to be applying what we know about individual drugs to how we're going to use them in these types of patients here. And again, why do we focus specifically just on pediatrics? They're totally different populations there, right? So again, how you manage an adult patient is going to be entirely different than a pediatric patient based on the fact that they're very heterogeneous, right? So dealing with, say, a 3-month-old is different than dealing with a 3-day-old, is different than dealing with a 3-year-old, right? So again, they change so much in just short periods of time. You need to be aware of that. And again, it's not uncommon when I'm working at Nemours on Mondays that I'll get an order for a 2-day-old, and then the next patient I'm getting an order for a 6-month-old, and then for an 18-year-old. Again, you have to constantly be kind of switching gears in your mind of like, okay, what am I dealing with? What kind of patients am I dealing with? What do I need to think about in terms of the medications? And again, is it easy to do a lot of clinical studies in pediatric patients? It's not, right? It's not really ethical to do that because it's hard to get consent or assent from those patients there to do these studies. And so a lot of times what we're doing is taking adult data and trying to back extrapolate it to those pediatric patients, which again is not always going to be one-to-one in a lot of cases there. And again, you'll have questions too that will come up and it'll be like, well, this drug says it's not indicated for patients like less than 12. Well, do we still use drugs like that in kids less than 12? All the time. It may not just have an FDA indication, but we still do have clinical evidence or clinical experience to know that it's probably okay. Again, when we're talking about the pediatric lingo, so to speak, especially when you're dealing with like neonatal patients here, we talk in terms of things like gestational age, we talk in terms of things like postnatal age as well. Those are the two most common ones. What's a typical gestational term for a patient, for like a neonate? 37, maybe it's like 40, 41, 2 in some cases, so around there. And so why does that matter? Why do we care? Because what happens if they're born really premature? Like what if they're born, say, they have a ton of issues, right? Because again, they have not had enough time to bake in the oven, so to speak, to develop things like functioning kidneys and livers and things like that. And so they can have very different ways that they're going to handle these drugs as opposed to someone who had maybe a full-term delivery, right? And so something you really have to take into account, and again, it's not something that's as easy as, because when you look at an EMR, electronic medical record, you just look up at the top and it says, oh, it's, Johnny, Sue, and they're 6 days old. It doesn't tell you anything about the gestational age, which is really important because that can change how we're going to dose a lot of these drugs here, right? Postnatal age is also important, though, knowing how chronologically old that they are. But even if you have, say, 2 children, one was, say, born at 38 weeks and is now a month old, versus one that was born at, say, 24 weeks and now is a month old, are they going to be functionally the same? Absolutely not, right? They're still going to be very different from one another, and it's important that we consider that when we're doing things like picking which drugs we're using or how we're dosing the drugs for those patients there. What's kind of the earliest sort of viable term for an infant? 24 weeks. I've seen a few that have been like 22 is the earliest I've seen, but that's very rare, and it's very they're very sick patients. And again, over at Nemours, like, we don't really have any people being born over there, or at least we try to prevent that at all costs, like get them out to an adult facility. But we get a lot of people transferred into us, and so we see a lot of the really sick kids, and that's where we get a lot of these really premature infants coming in. And again, when I say, what's the difference between like an infant and like a neonate? Well, sure, like physiologically there's differences, but in terms of like, how do I define that in terms of like ages? Yeah, neonate's going to be that first month, that first 28 days of life. An infant kind of encompasses the first year. So you may hear me interchangeably refer to like a neonate as an infant. That's still technically true, but a neonate is really just that first 28 days. Now, where do you find a lot of your neonates in the hospital? The NICU, which is a neonatal intensive care unit. Does that mean once they hit 28 days, they get kicked out to the floor? Not typically, right? You may keep those kids in there until they're really ready to fly, so to speak, for say 5, 6, a year, 5, 6 months, a year potentially, so they can stay there for quite a long time. Certainly as they get older, toddler range about 1 to 2, and then you start getting into the young children, older children. When do they start acting like adults in terms of the kinetics, do you think? Yeah, around the teenage years is when we start to consider, okay, yeah, you're probably pretty well mature in terms, a 16-year-old is not mature by any stretch of the imagination, but in terms of physiologically speaking, the current pharmacokinetics, they're fairly well mature. And it's not uncommon that you'll get, say a 16-year-old, we have a contract at Nemours with Disney, so if anyone gets injured there, any kids get injured there, they come over to us, and so they have like a lot of tournaments, like, in the summertime we get a lot of cheerleading tournaments and football tournaments and all kinds of things like that. They'll get transferred to us, and it's not uncommon you'd see a 16-year-old that weighs like 100 kilos, 120 kilos, in which case, 16-year-old, I don't know, I'm trying to think of the heaviest 6-year-old I've seen, but maybe 60, 80 kilos, something like that. There's certainly some extremes there you'll see. But point being is that when you have to start considering like dosing like an adult patient. Once they start hitting adult weights, that's when you want to start thinking about it, because we already alluded to the fact that most of our dosing is going to be done as weight-based dosing, and once you start to bump up against those adult caps is when you want to start capping off your doses. So for instance, say for instance like a dose of ibuprofen for a patient, which is something you give like water out in the ER, is say 10 milligrams per kilo. Okay, anyone know what the adult max single dose of ibuprofen is? 800 milligrams, right? So if I have a 90 kilo kid that I'm dosing, 90 times 10 would be 900 milligrams. Would I give them the 900 milligrams or cap it off at 800? Cap it off at 800, right? So it should be somewhat common sense in terms of like thinking, all right, when am I going to cap this out? And once you hit adult doses, that's where you want to stop at that point, for the most part, right? There's maybe some exceptions to that rule, but that is generally what we're talking about there. So again, let's kind of review the kinetics and again how they're changing, especially in the very early stages of life, and how that's going to be affecting how we're using these medications here. Again, consider in terms of drug absorption how these the actual physicochemical properties of the drug is going to be a factor, along with the patient factors as well. So for instance, things with like a large molecular weight or large particle size, they have an easier or more difficult time crossing a membrane. They have a harder time just because they're bigger and it's harder to force their way through there. But we'll see the pH and pKa matter. We'll see that the dosage form matters. And so this can really be dictating how we're using these medications. Maybe orally is not going to be a good route for some patients. Maybe rectal is going to be a better option for them, or intramuscular. So we'll see some different options there. So in terms of gastric absorption, especially early on, we're going to see there's big changes in terms of gastric acidity versus gastric emptying time as well. So for instance, when a child is first born, what do you think the gastric acidity is like? Because a normal, say, gastric pH is what? Like 2, right? So what do you think it is for like an infant? Higher probably, right? How high do you think? Probably pretty neutral, because what do you think kids kind of been passively ingesting while they've been in the womb? Amniotic fluid, which is typically fairly neutral, right? So you'll find that the pH is going to be a lot higher there, and that can affect the absorption of medications, right? You can see things like weakly acidic drugs maybe having a harder time getting absorbed because you're putting them into a more basic medium, right? Especially that first couple of days until the acid production really starts to kick in there. So you'll see that changes pretty drastically depending on the age of the kid. Gestational age also matters as well, because the more premature they are coming out, they're not really designed to start eating yet, and so say you have like a 28-weeker, even though they may be a day or two out, they're really not kind of kicking up that acid production like you would expect. So just little things to consider in terms of drug administration for those types of patients there. For basic drugs though, they may have an easier time getting absorbed during the first couple of days there. And then usually by the time they're about 3 months old or so, they should be sort of at adult levels for that point. So at that point, it's less of a concern from that standpoint. Same point a lot. How about gastrointestinal emptying time? How do you think that, how does that compare, say, for an infant versus, say, an older child? It's a lot shorter, right? It's a lot faster in the infant, right? Anyone have an idea how often, say, like a newborn poops? All the time. It's quite frequent, right? It's okay, though, because they don't really stink when they're first coming out. So something to consider. I don't know if any of you are going to have kids eventually, but things you get to look forward to is changing a lot of poopy diapers very early on. And so that's important because, again, what does that do in terms of contact time between the medication and the GI tract? It shortens it, right? So it may delay absorption. That's why you don't see a lot of controlled release preparations or extended release drugs that we give to newborns, because of the fact that they're just going to pass it through very quickly and they wouldn't have a whole lot of contact time there. But you may find there's issues. Maybe there's anatomical issues. We have kids who have congenital heart defects, or maybe they're not going to be perfusing the GI tract as well, and that may slow things down, right? You have other issues that may affect that gastrointestinal emptying time pretty significantly there. Also, things like type of feeding can be important, whether they're breastfed or formula fed, if they have lactose intolerance and things like that, can all be playing a big role there. And so those are things that, especially when talking with like your nutritionist folks, they can really help out a lot with that in terms of like feeds and whatnot. So again, shorter time means less time with absorptive contacts. You may find that there's differences between different patients in terms of how much they absorb and what the serum concentrations may be depending on that gastrointestinal emptying time. So that's something just to consider for those patients. Looking at extraoral drug absorption, how do you think things like muscular blood flow changes, say, for like a newborn versus, say, like a kid who's 2 or 3 years old? Like do they move a whole lot, like newborn, the first couple of days of life? No, they're like a little burrito. Usually you kind of wrap them up, not really moving a whole lot at that point, because again, you want to make sure that they're kept warm and all that, because they can't really regulate the body temperature as well, versus like a 3-year-old. Are their muscles moving around a lot? You cannot stop their muscles from moving because they're always doing something, they're always getting into something. They don't stop. They're little energy vampires that suck all the vitality out of you. We took our kids to SeaWorld the other day, and it's like they were running around constantly the whole time. We get home, and we are wiped out, me and my wife, and then the kids are still just like, let's go outside, let's go play, let's do this. I'm just like, stop. Don't, and no more. But then they slept like rocks, so that was great. So anyway, so we'll see that there's a difference here, and that can affect absorption. So for instance, if I were to give an intramuscular dose of a medication to a newborn who's not really moving around a whole lot, what do you think it does to absorption? Ultimately, overall absorption is going to still be the same because the muscle's still there, or the drug's in there in the muscle, but it may slow it down. You may not find that the serum concentrations really get to where you want because it's being delayed because of that. So little things like that we're going to consider as well. So you want to think about blood perfusion to the area where things are being injected potentially. You want to think about things like how well the drug can pass through those capillaries, and also think about the volume of distribution for these drugs. Especially neonates, you want to think about them in terms of like being kind of just big bags of water in a lot of cases. They have a very high volume of distribution for hydrophilic medications because, one, they don't have a ton of muscle mass, and they have a high body water percentage. And in fact, when kids are first born, they typically end up diuresing quite a bit in the first couple of days. Why do you think that happens? they're kind of waterlogged from all the amniotic fluid and everything they've kind of been absorbing from mom. So typically, you see once they're born, they'll actually lose weight during the first day or two, and then as they are eating and feeding and whatnot, they'll actually kind of put it back on in those cases there. So for instance, I know like so my second daughter, she was born on December 20th, so it was right around Christmas time. So usually at the first couple of days after you get out of the hospital, you typically go with your pediatrician for just a well check. And so we were worried about scheduling around Christmas time and everything. So we were able to get out of the hospital and we were able to get an appointment right before Christmas with our pediatrician. So we went to see them and they're like, oh, I don't know, she's lost some weight, she's not putting on weight. We're just like, oh, this is not good. But I was like, wait a second, like she's my kid, like she can eat, like that's gonna not be a problem. And then of course she comes back right after Christmas, right around New Year's, and they're like, yeah, she's like 99th percentile for her size, so her age, so she's good. So little things like that you want to consider in terms of like the volume of distribution, because they do hold on to a lot of fluid initially. But we'll see that again, decreased contractions will decrease overall extent of drug penetration, and it may have some vasomotor instability as well. So if they're not going to be able to regulate that vasodilation or constriction because their temperature can't really be all that regulated, that can also affect it as well. So we see that a lot, especially with like kids with neonatal abstinence syndrome. Have I mentioned that before? What is that? And kids are withdrawing from whatever the mom was taking during pregnancy. So we see that quite frequently in the NICU, where kids are not able, they're really, they're withdrawing, they're not really feeling all that well, and they don't feed well, and they can't really regulate their temperature as well. So that can be a big issue as well. How about rectal absorption? You think that's pretty good in neonates and infants? It's very good, right? So again, thin membranes. As long as the drug can cross over, it's sufficiently lipophilic, you'll have pretty good absorption in those cases there. But you have to consider things like the number of rectal contractions that they have, right? So we mentioned that especially neonates, like they poop a lot, right? Infants poop a lot. So again, you may put a suppository in for that patient, but if they poop it right back out, is it going to absorb? So sometimes just consider things like, okay, let me go ahead and put the suppository in, close their cheek shut for a little bit, give it time to melt and have time to absorb, little things like that to think. Because frequently you'll find they'll put a suppository in, they'll take a diaper off later and find that the suppository is just sitting there in the diaper. And it's like, well, they just wasted the whole dosage for them, okay? So little things like that, again, consider in terms of drug absorption and is it actually staying at the site. Now, getting an IV in an infant, for instance, does that sound pretty easy? Pretty difficult? No, it's quite difficult because they're small, very friable sort of veins as compared to an adult. So what can we do if we're like in an emergency standpoint? Well, we can use these kind of nice non-compressible veins called their bones, right? We can just inject things right into the marrow essentially and allow for that to absorb systemically. So that's a good alternative. And frequently if you have like EMS that's responding to say an infant is found apneic or something, or they're not responsive, EMS will arrive. They may have a difficult time getting an IV, especially think about being in the back of a EMS is bumping down I-4, like that could be pretty difficult to get an IV started. They'll frequently use an IO, right, an intraosseous device, and basically it's like a little power drill here, which looks like kind of a thumbtack you're putting in, and depending on the size of the patient, they'll use different ones. The tibia is quite frequently used, but you could use things like the humerus, the sternum, a lot of different options there. But the nice thing is that you can get really any drug through there. You can do fluids, you can do code meds like epinephrine, you can do everything through that, which is nice until you can actually get a true IV started. Anyone know if these are painful? Reportedly, they're not supposed to be that painful as compared to like an IV. I'm not going to be the one to test it though, but adult patients don't seem to think it's all that bad. But again, if they're an infant and they're unconscious, they're not going to know anyway, so again, do what you got to do. Now, in terms of percutaneous drug absorption, this is also really important because, especially with an infant, their skin is relatively thin. They don't have a really developed stratum corneum, and such that they can have really easy absorption of things across those membranes. So, for instance, like you could see with iodine. I know we haven't talked about thyroid stuff yet, but if you have patients who are absorbing a lot of iodine, that can actually inhibit thyroid hormone formation, which is also kind of counterintuitive because what do you need in order to form thyroid hormone? You need iodine, right? So if you get too much of it, though, it can actually shut that process down. So you have infants that develop hypothyroidism because they're absorbing too much betadine, which has iodine in it, as a cleanser, so we don't use that anymore. Or for instance, they used to use things like isopropyl alcohol to try to clean off those infants. And they would actually absorb the isopropyl alcohol and basically get drunk essentially, but they would also develop hypoglycemia as a result of that. So you want to consider the fact that especially with their body surface area, as opposed to their weight, the even small areas being covered of them in terms of percentages, it can still be a lot for them. So that you want to be certainly cautious with. Now, we're talking about the distribution for these drugs here. Again, Think about little kids, especially infants, as kind of big bags of water. They're going to have a very high distribution of medications that are hydrophilic specifically. And so you're going to see your drug dosing is going to differ pretty significantly here. So just to give you an example of other things that can affect that distribution, we see things like lipid solubility, the plasma protein binding will affect that. If you have drugs that are being highly bound to plasma proteins, what would that do in terms of your volume distribution? Increase it or lower it? It would lower it. Why would it do that? It's not getting to the tissue. More of it's being held in the actual bloodstream there. Very good. Tissue binding would do the opposite effect, as you would see there. And then just thinking overall of peripheral tissue distribution. But, you know, we also know that critically ill patients also can have altered volumes of distribution due to things like edema, burns, and whatnot. So, as I mentioned, with a newborn, you'll find that 70 to 75% of their body weight is just water, right? So again, they're big water balloons essentially, and you'll find that their extracellular water component is a lot larger than you see with an adult. So in terms of, say I had a hydrophilic medication, say something like gentamicin is a good example of this, how would I have to alter the dose on a milligram per kilogram basis for an infant versus say for an adult patient? The hydrophilic medication, I want to get the same blood concentrations though. I'd have to increase the dose, right? Because I have a bigger bucket I'm trying to fill, so I need to put more drug into it to get that same concentration, right? So kind of think about the bucket sort of mentality. And you can think of kids as having a larger bucket. Also, it's hilarious when you put your kids into stuff and you can take pictures and it's fun. But that's not my kid, by any means. But anyway, so overall, you'd find that these kids would need a higher dose on a milligram per kilogram basis than you would for an adult patient. So as an example of this, gentamicin, right? So if you're looking at the actual volume of distribution for, say, a neonate versus an infant versus an adult, you'd find here it's 0.5 to 0.6 liters per kilogram. So it's like, you know, 2 to 3 times higher than what it would be for an adult patient. So what do you notice about the dose that we're giving? It's about 2 to 3 times higher as well. And this should net the same serum concentration, which is important when you're considering like treating an infection, right? You have to get the right concentrations to actually treat that infection there. And so you'll find that we may give a larger milligram per kilogram dose, but we'll also see that the elimination is also going to be playing a role here as well in terms of the frequency that we're going to be giving these drugs. So also you'll find that especially kids very early on, they may have decreased tissue proteins. So for instance, they may have lower albumin stores. You may find that certain proteins may be bound up already with things like bilirubin, which is a good reason why we don't give things like, or actually do you remember the antibiotic we don't give to kids less than a year old because of this risk? Causing hyperbilirubinemia. It's a cephalosporin. It's a third generation cephalosporin. Prostafen, ceftriaxone. Yeah, we actually don't give it in the first month of life because it will compete for the same binding sites as bilirubin. We'll kick it off, and then all of a sudden the kid looks yellow, looks jaundiced because they have all this bilirubin that's now free. And so that's one thing we will not use. We'll use something like cefotaxime instead pretty frequently. Other things though, things like phenytoin. We talked about phenytoin in terms of treatment for what? Seizures, very good. And you'd actually have higher free fractions of the drug there. So instead of saying it being 90% protein bound, maybe it's only 85%. Right? What could that lead to in the patient? A lot of toxicity because all that free drug can interact with those sodium channels, and you can see increased sedation, ataxia, etc. Right? So again, don't memorize this slide, but just to give an example how things can either be reduced at birth or they could actually be increased in some cases there, depending on where they're at. But then again, as they're infants, normally things will start to normalize there. By the time they're children, they're pretty close to adults at that point. So really the neonatal period is where we're really concerned about this. So looking at things that affect metabolism, we'll also see that gestational age plays a really big role in terms of how well they can metabolize and excrete drugs, as we'll see. Also things like changes in hepatic blood flow, you know, congenital heart defects can have a big effect on this. How well they're actually producing enzymes and whatnot. So if a full-term kid comes out, do you think they have like a fully functioning liver in terms of all the enzyme systems? Definitely not, right? And then if you had a premature infant born, they're even worse off. They may even have even less of that in those cases there. And then consider things like maybe you have other drugs that are causing induction or inhibition of those enzymes additionally. So if you recall, just a brief recap, remember we have phase 1 and phase 2 metabolisms that occur in the liver. Remember what phase 1 does? kind of modifies the molecule, typically making it more water soluble. This is where our CYP enzymes come into play because it's part of that oxidation process. You have other things like hydrolysis and whatnot. I only mention this here because I'll talk about a few examples of how certain medications or certain substances can't even be used in pediatrics, especially in neonates, because they just can't even process it well because these systems may not be fully expressed. So examples, things like phenytoin, we may find that by 1 year of age, we actually have to give a higher dose on a milligram per kilogram basis than adult patients because they actually have overexpression of the enzyme. They can actually have way too much of it as compared to adults, and that then normalizes out as time goes on. So it could either be depressed, it could be elevated, just depends on the situation there. Other examples would be things like chlorohydrate. Anyone ever heard of chlorohydrate before? It's a really old school drug. They actually stopped making it a couple of years ago. I think when I was in fellowship, they stopped making it. But basically, it used to be like a really good sedative for NICU patients, PICU patients, because these kids didn't really have as good an ability to metabolize it, so it stuck around for a long time. So you could use very small doses and get nice sedation in these children, as opposed to using like an intravenous infusion or something. Anyone ever heard of the concept of slipping someone a Mickey? Never heard that? Any Seinfeld fans? At least know there's one. You have a Seinfeld sticker. So slipping a Mickey is like an old school term, is like where there's a bar called Mickey Finn's where the bartender used to slip patients, or it's not patients, they turned into patients essentially, but he would slip customers the chlorohydrate into their alcohol, and so the two together actually cause a nice drug interaction where they extend the half-lives of one another. And so these patients, how do you think what would happen to them? They'd pass out essentially, right? They're just way too drunk. And so then the bartender would steal their wallets and the money out of the wallets, wake them up, be like, hey, you're too drunk, get out of here. And then that was slipping someone a Mickey essentially. So that's chlorohydrate. We used to use that for infants because it was a really good sedative agent for them. Turns out infants don't really have a whole lot of money to steal. We tried that and it just didn't work too well. Anyway, but you'll see that different enzyme systems will mature at different rates. So for instance, you'll see within hours of birth, 2E1 starts to upregulate. You'll see that things like 3A4 and the 2C family are going to be present within that first month or so. So it just is different. And when you look at a drug dosing for a neonate, for instance, if you're looking at LexiComp and you go to the pediatric specific one, there's a whole section just for neonatal patients. And all that dosing has already been taken into account. They've already kind of figured all that out for you, but I want you to kind of understand the background stuff, why these things are different between a neonate versus a pediatric patient versus an adult. And some of it has to do with things like the metabolism. Now, phase 2 reactions is we're adding something on to the molecule to typically make it more water soluble, getting it ready for elimination through the kidneys. So this is where you have like your sulfation pathways, methylation, etc. Right? So different processes here. So just give you some examples of how things can change. For instance, with very small children, even for the first couple of years, they have a really good functioning sulfation pathway. And this is an important pathway for things like acetaminophen. If you have too much acetaminophen, what's the risk? What are you worried about? Yeah, we're about liver toxicity. And so just to give you an example how this can actually impact things clinically, if, say for instance, I'm taking call for the poison center and then someone's asking, hey, is this too much Tylenol for a patient? Typically for adults, it's around 150 milligrams per kilogram. Anything more than that is considered to be potentially toxic. For kids, because we know they have a good sulfation pathway, our threshold is actually around 200 milligrams per kilogram. So again, we would say, for instance, maybe if I had an adult patient that ingested 160 milligrams per kilogram of Tylenol, I would send them into the ER for potential treatment. If it was a kid who got that same amount on a milligram per kilogram basis, I don't even do anything with them, right? Because the risk is just not there because they have a really good sulfation pathway. So different how we can manage patients based on that process. Other things include things like glucuronic conjugation, or actually glycine conjugation, one I want to mention here. So for instance, there's a preservative that you'll find in a lot of IV products. So if you ever look at an IV vial of a medication, it'll either say single dose or say multi-dose. To make it multi-dose, what do you think we do to it? We add preservatives into it. We add things like things that keep it sterile between uses, right? Because you don't want to get your vial infected with something potentially. So there's a preservative we use in multi-dose vials called benzyl alcohol. And these kids, they actually can't process, especially neonates. And so what happens is they end up not being able to process it, they end up developing this metabolic acidosis, and they get what they call this gasping syndrome that occurs. And so because of that, we make sure that we only use single dose vials for neonates, right? So actually change which drug products we're going to be using, whether it's single dose or multi-dose. And that can be important because if you screw that up and give these neonates the wrong one, that can potentially lead to their death, right? So little things to be cautious with. Hopefully your pharmacy colleagues will be able to get this one figured out and you don't have to think too much about it. But again, that's why we use only single dose vials for neonates. So, and then in terms of excretion, you're going to find that typically the more premature the child is coming out, the less functional their kidneys are going to be. How do you determine kidney function in a neonate? Typically, urine output is going to be pretty good. You'll see that the serum creatinine is not going to be a good surrogate marker for at least the first couple of days or so when they're first born. Why is that? Remember, it's falsely elevated. What do you think that is? Yeah, it's actually the mom's serum creatinine you're measuring there for the first couple of days, and so you'll find that you'll see that actually trend down over time. Because again, where does creatinine come from? It's a byproduct of muscle metabolism, and so we mentioned these neonates, so they have a whole lot of muscle. Typically no, right? So again, this is where you're getting a lot of that from, is from the mom. But they can still have underperforming kidneys there. So we look at things like urine output. What's a good urine output for a child? How about for an adult? You guys know? Well, we usually use like mLs per kilo per hour. Anyone know? In general, okay, so when you're on rotations and stuff, again, I always want you to look things up and have a really good answer before you say things. A lot of times you can just say like 1 something per something, and most of the time you're going to be right? As it turns out. It's weird, but so for instance, with like adult patients, 0.5 to 1 mLs per kilo per hour is considered pretty good urine output. For pediatric patients, especially like neonates, anything greater than 1 ml per kilo per hour is considered to be normal, right? And especially in that first like initial diuresis phase, you may find they're up to like 5, 6 mLs per kilo per hour. So they are producing quite a bit of urine there. If it's less than that, that's where we're really concerned about the kidneys are not functioning properly. But we have to consider things like their gestational age. We consider things like the nephrotoxic medications they might be on. Maybe they're on gentamicin because we're worried about neonatal sepsis, different things like that, and how that may affect how well they can excrete these drugs. So as I mentioned, GFR is not going to be all that too helpful, especially when you're dealing with like a neonate. For children, we do have calculations that we can use there. So anyone remember what we use for the adults to determine their creatinine clearance? The equation, it's called Cockcroft-Gault, right? That's one we use for adults. You can't use that for pediatric patients. Why not? It's just not validated for them, right? How do we get these calculations? How do we get these equations? Someone did a study, right? Someone did a study with a bunch of adults, and they came up with a model that said, okay, this is how we think we can predict creatinine clearance. If it's only done in adult patients, you can't extrapolate it to pediatrics. We have other equations we can use for them. So we use what we call the Schwartz equation, and that tends to be a pretty good one for our pediatric patients. But neonates, it's still not even all that effective because they just don't have good serum creatinine to measure. Anyway, point being though is that as the more preterm they are, it also affects how well functioning their kidneys are going to be, and you'll see that they're going to be still pretty immature. And so I think this graph does a pretty good job of explaining that. So for instance, you have a term infant versus preterm and then very low birth weight infants here. You'll see that looking at their GFR, in terms of mLs per minute, you can see that even by the time that you're 2 weeks out, the preterm infant here is still not even up to the term infant levels, right? Because they probably came out more than 2 weeks early if they're that low birth weight, right? So these are things to consider, as they may be quite a while before they're actually up to normal sort of, for their age, sort of creatinine clearances. And so that has a role to play as well when you start thinking about in terms of their GFR. So we can see things like a neonate might be 30 to 40. Usually by the time they're about 6 months old or so, they should be close to adult levels. And so we can start using that in terms of our drug dosing and in terms of how frequently we're going to be giving these drugs here. But we certainly know it's going to be diminished early on. So here's the thing I want to point out though, is that affects the half-life of these drugs pretty sufficiently, or pretty extensively. If you have a lower GFR and you're dealing with the hydrophilic medication, something like gentamicin, what's that going to do to the half-life? I'm not filtering as much, I'm not clearing as much, it's going to extend the half-life out pretty significantly, right? So for instance, if you're looking at gentamicin, you can see here that it can range anywhere, and this is depending on their gestational age, between say 3 to 11.5 hours. Although to adults, maybe 1.5 to 3, so it's again pretty different there. How do you think it's going to affect how I'm using the medication? You think I do up the dose? Yeah, you give it less often, which is important too, because remember what do we say about the distribution? We had to give a bigger dose on a milligram per kilogram basis, but we also have to give it less frequently. So we give a bigger dose less often in order to get the same levels as you would see for an adult patient. Okay, and then even you have to look at things like, well, what was their gestational age? If they were say between 32 weeks and up, maybe you give it every 12 to 24 hours. If they're maybe 24 weeks, we give every 48 hours potentially. So it could be quite a long time between drug dosing intervals because they just know their kidneys are not clearing it that well. So these are important considerations. Make sure if you're dealing with a neonatal patient, you're looking up their gestational age and seeing how that has a role to play in terms of how you're dosing your medications there. Does anyone even want to work in peds? A couple of people. Or just 2? Interesting. Most of you probably don't know what you want to do yet anyway. But are you going to run into pediatric patients no matter where you go? Unless you're working on the villages or something. But yeah, for the most part, you're going to be dealing with pediatric patients at least a little bit. So again, it's still good stuff to know. And again, looking at things like secretion, reabsorption through the kidneys, you're going to find that's going to be fairly well diminished. And again, that's all going to be affecting how well they can clear those drugs in terms of their half-life. So let's go and do a 10-minute break. We'll come back and we'll finish out this section and then move on into the Jerry's. How will it be tested on the pediatric geriatric PowerPoint? It's a good question. I didn't even know you could spin those around. Just didn't put it like upside down or something. How do you think it'll be tested on the pediatric geriatrics PowerPoint? It's a very interesting question. I guess if I don't know, then I don't know. Calculation? That's a good idea. I should put some of those on the test. Interesting. So we will likely have some calculations on the test, pediatric fluid calculations, prescription dosing, things like that. I will allow you to bring a calculator. I'll make sure that that message is passed along. But because you can use a calculator, it means I get to use more decimals and stuff. Otherwise, if I don't let you use calculators, and it's just like whole numbers and dividing by 5 and 10 and stuff like that. But I don't want to shortchange you your educational opportunities, so I'm going to make it more difficult, okay? No, thank you? That's okay. So anyway, you'll be able to do that. You've done it for the prescription assignments before, so it should be easy points, to be honest. Because again, you only have 5 choices. And again, so if you screw something up, like, it should be pretty obvious if you don't get a wildly different number. I should hope, at least. But anyway, so again, a lot of this is going to be conceptual stuff, right? So it's going to be more like how might you use a medication differently in a pediatric patient versus an adult, or in a geriatric patient versus an adult. Things like that. So again, it's more concept-based. It's not going to be strictly as something like HIV, where it's like, okay, which one of these regimens is most appropriate, or which one of these drugs would cause this side effect. It's less of that, more conceptual. That helps at all. Likely not, though. So I'll just continue anyway, though. Anyway, I did make an error here. So it said slower GIT. I meant to put shorter GIT. So it's a faster. It's going through, things are going through faster. It's a shorter time, essentially. Time's hard to talk about, and sometimes. But that was slide number, where am I at? 10. Okay, getting back into, so anyway, so there's a lot of variability in our drug response we'll see with these pediatric patients. And so again, it's always really important to take into account all these different factors, right? So again, think about things like the pharmacogenetics and why some pediatric patients may react differently to medications. Certainly their size. I mean, do you have kids that come in the extremes of weight, both under and over ever? Certainly, right? So we have a lot of like overweight children. We have some kids that have chronic diseases where they're coming in very underweight. I'll tell you a really good example I had the other day. We have residents now over at Nemours, and so my job just got a whole lot more exciting because now I get to find all these fun drug errors that I have to catch before they get put out. Usually, if you're working with like a hospitalist or an ICU doc that's been working like for years and years and years, they're usually telling me what to do. Versus now I got these residents and I got to tell them what to do, right? Anyway, I'm just kidding. It's a very collaborative approach. But yeah, you really got to catch these residents. Just like I'll have to be watching out for you guys if I end up working with you for the first couple of months or so to make sure you know what you're doing, right? So anyway, point being is that we had a patient and I had an order that come through, and the patient was 20 years old, which is not normal for us to have a kid that old, but frequently if they have a lot of chronic illnesses that are being managed by our pediatric caregivers, we'll continue on with them for a period of time. So I had this 20-year-old patient, and the order came through for an adult Fleet's enema, okay? Remember what is in a Fleet's enema? It's sodium phosphate base, right? Remember we talked about things like electrolyte disturbances that can occur in like these streams of age. You have to be really careful using that. It was back in the GI section all those many moons ago, right? But anyway, so I was like, okay, an adult Fleet's enema for a 20-year-old makes sense until I look at the weight. This patient was like, I think 19 or 20 kilos. Is that abnormal? How many pounds is that? Like 40, 44 pounds, right? Like this is a very underweight patient because they had a lot of like chronic issues. They had CP, they had a lot of, they had some kind of mitochondrial disorder or something like that. It's a very complicated patient. So I called the guy up and I was like, hey, so I saw you order that adult Fleet's enema. And they're like, yeah. I go, you know, they're like 18 kilos, right? Like, they're like, oh. They just look at the age. So you gotta be really careful. Age can be misleading in these patients here, and either direction, over or underweighting there. So we end up getting them, actually we end up using just a pediatric dose for them, which is more appropriate. Because again, if we had used the full adult on that size patient, you could potentially cause some severe electrolyte disturbances, hyperphosphatemia. It could have been an issue. So anyway, little things to consider for these patients here. Remember, things like genomics can make a difference in terms of metabolism. We talked about how codeine, we don't use in pediatric patients anymore because some of them are going to be ultra rapid metabolizers. And if you remember, codeine turns into what? Morphine, right? So these kids are producing too much morphine. These are usually like kids that are undergoing TNAs. They come out of surgery, they already had issues of obstructive sleep apnea. And what happens to the throat, you think, when you go and cut out the tonsils? It swells up, right? So they have OSA, they're starting to have the swelling here. Now all of a sudden their respiratory drive is being blunted because they're converting all this codeine into morphine. Guess what happens? They go to bed, they don't wake up, right? So because of that, we actually got rid of it off our formulary. We just don't use codeine a lot for those kids anymore, right? We still use it sometimes for our advantage, and you'll see a lot of patients with sickle cell disease happen to be on codeine quite frequently to manage their chronic pain issues. Why do you think that is? Who gets sickle cell? More likely to be black patients, and guess what? Black patients typically are more likely to have an ultra rapid CYP2D6 metabolism. So guess what? They do really well with that drug because they convert a ton of it over to morphine and they get good pain management from that, versus say like white patients, maybe not so much. So those are things you have to consider, and it's hard to be able to determine just based off looking at a patient unless you were to actually do the testing there. Is there any HIV drugs you have to do genetic testing on before starting? Abacavir, yep, absolutely. That's a good thing to know. So anyway, right, we have a lot of different dosing regimens here. We have things like age-based dosing, but again, that can be misleading if you have kids that are at the extremes of weight. Certainly, it's still used occasionally. It's easy to remember in a lot of cases, but we try to not use that because, again, the kinetics of drugs are not going to be the same in every single patient just because of the same age there. We do a lot of body weight dosing. Again, remember to cap it out usually around the adult levels. You don't want to go beyond that, and at least a good starting place for a lot of those patients there. Most common, keep in mind though that depending on certain features, like you could have kids that even though they have say for instance they are overweight, and so they are maybe capping out those adult doses, but most of it's adipose tissue. You have to consider things like the volume distribution for that as well, and that may not be appropriate. So I think we had one patient, I don't remember what drug it was we were using for, but I think they were like, I'm trying to think if they were like 10 or 12 or something like that, but they're like 100 kilos. So it was an adult-sized patient essentially, but a lot of it was due to adipose tissue. And so we were working with the physicians to come up with drug dosing for certain antibiotics, and we ended up going with like an adjusted body weight. We tried to adjust it down based off what her ideal was versus what her actual was, and try to find a happy medium. And there's some calculations you can do that based on their height and things like that. So again, always take it with a grain of salt. And we actually have alerts that pop up for us in our EMR where it'll tell us, hey, this patient is 25% outside of the CDC growth charts, essentially, in terms of like what their weight should be typically. And so that serves as an additional flag to maybe look at it and say, okay, what's going on here? And do you think there's ever any issues where people will document weight in pounds and then it gets interpreted as kilos and vice versa? Absolutely, that's another big concern there. Like for instance, at our hospital, all of our scales, we just turn off the pounds features. That way you only can weigh in kilograms, you can only input kilograms, and that prevents some issues there. But like if I go to my pediatrician's office, they always weigh my kids in pounds. That's what shows up on their chart. So again, you want to be cautious with that. Make sure you're always talking about the same units there. And frequently I'll call down to the ER and be like, hey, this patient came up with this weight. Are you sure that's accurate? It's not pounds. And they say, yeah, it's definitely accurate. So just be cautious with that. Anyway, body surface area is going to be an even more exact way of dosing. This is where we're going to factor in the kid's height and their weight together, and we do this frequently for chemotherapy. This is the most common thing I'll use it for. We may do something like vincristine 1.5 milligrams per meter squared, right? And again, you have to calculate that. There's different calculations, so be consistent in which one you're using when determining a patient's body surface area. Now, in terms of giving intravenous drugs here, you want to consider things like the site of administration. We're talking about things like peripheral versus central administration, because typically, when you think about drug concentration, do you think we'd want to give more concentrated drugs or less concentrated drugs, say for like instance, like a neonate? Well, think about the volume of fluid you're actually having to give for these patients here. It's not, if you think about a kid who weighs, say, 2 kilograms, what's a fluid bolus for a 2 kilogram kid? Remember what the fluid bolus dose is? 20 mils per kilo, so 20 times 2, 40 mLs. Is that a whole lot of fluid? That's like a shot of alcohol, right? Almost not even a shot of alcohol. So from that standpoint, you have to make sure that we're looking at things like, are we concentrating our drugs so that way we don't fluid overload these patients? And so that can be a concern. You have to think about things like drug sampling, because again, if you're going in for different labs, you want to consolidate those because you can actually have a significant effect on their hemoglobin because you're drawing so much blood out of those patients. There's a lot of things to really consider when doing IV drug administration. Pumps are always going to be super helpful here because again, you never just want to hang something on a pediatric patient, especially a neonate, and just walk away, because there's been cases where whole liters of fluid have gone into a neonate. All of a sudden they have flash pulmonary edema and have died before. So that's why we make sure we use things like pumps to help us out, make sure that we're mechanically, we can only give so much or drugs so fast. And so an example here, like a drug pump that we use, this is one we use over at Nemours, has a whole drug library built into it, such that it only accepts certain concentrations, certain dosing parameters. Oftentimes all the nurses call up, say, hey, I can't put this drug in because the dose is too high, or the concentration is off, or the timing is off. And so it's important we have those safety features there. We call it guardrails, and you never want to go off guardrails, right? Because again, if you cause an error and something bad happens, and they come back to you, it's like, well, why'd you do that? And you're like, I don't know, I needed to do it, and I just did it. And like, well, you didn't follow the safety features, and then you're culpable for that. So we always want to be cautious there. Anyway, with oral administration, what are some things to consider here? Can they take it orally? So what dosage forms can they tolerate? So things like, can a 2-year-old take a tablet? Not likely, right? Unless it's maybe like an oral disintegrating tablet, or maybe if it's like a chewable medication, that could be one thing, right? What are some other things to consider? Food interactions for sure, right? So again, things will bind up with one another. Kids typically drink a lot of what? Juice maybe, so sugar can be a concern. What's the other thing they drink a lot of? Milk, right? Calcium will bind up with a lot of medications there. You want to be cautious with. Hopefully kids aren't drinking too much juice, right? It's usually kind of a big problem. What else do you think of? How does this stuff taste, right? Like when you guys were kids, were all your medications, they taste good? Mine never tasted any good. Nowadays we have like orange flavored ibuprofen, and at first, when we first opened Nemours, we had a very cost-conscious pharmacy director. He ordered cherry-flavored Tylenol, and we almost had a nursing revolt because they said no, because we don't want to have all that cherry-flavored Tylenol spit back on us because it's gross. Get the grape-flavored. So we switched over and we paid more, and we got the grape flavor, right? What do you think it does in terms of accidental exposures to drugs? It increases actually, yeah, because you'll find that especially if you call like medicine candy, things like that, to try to entice kids to take it, that also causes a lot of problems. We'll have calls to the poison centers where parents will say, oh, they drank the entire bottle of Tylenol, or they ate an entire bottle of gummy vitamins, things like that you run into pretty frequently because of that. So these are all things you want to consider, the flavor of it, the texture, all of that can be playing a big role. Looking at how we're going to be prescribing these meds, again, make sure you get a current weight. Now, do you think I know, being an exemplary pharmacist as far as you know, with no disciplinary actions against my record that you know of, do you think I know like the weight of my kids right off the top of my head? I can ballpark it. I can get a decent idea, but imagine if one of my kids, say, collapse and need to go to the ER and I need to provide a weight for them for drug dosing. It wouldn't be exact, right? So make sure you're getting up-to-date current weights as best as possible. Make sure you're checking with available references. Make sure you're actually using good pediatric sources like Lexicomp. They have a whole pediatric library that you can go into. I'm sure when you look up your drug dosing stuff, you'll notice there's like regular Lexicomp and then there's like pediatric dosing. Make sure you're using that pediatric dosing for those patients there. And then in terms of counseling, make sure it's appropriate for the age. So obviously I can't tell a 2-year-old, okay, we're going to give you antibiotics for this. They're not really going to get it, versus telling the parents who maybe have the intellect of a 2-year-old. You never know. It just depends on the situation. Certainly if they're older, you want to tailor to what they can understand. Now, in terms of drug dosing calculations, it's good to remember the fluid dosing. For a fluid bolus, 20 mLs per kilo. And then for the maintenance rates, the 4-2-1 rule. You can't really go wrong with that, right? It's like a typical adult maintenance rate. It's about 125 mLs an hour, but you can still use a 4-2-1 rule for adults, and you'll still get pretty close to that for the most part. Keep in mind, if you ever see drugs being expressed as percentages, what that actually means. So for instance, if you see like a lidocaine 1%, basically what that means is 1 gram per 100 mLs, essentially. A good way to convert that over for us, a handy tip for that, is just move the decimal place 1 over to the right of the percentage. So for instance, if I have a 1% lidocaine, I'd move that decimal place 1 over to the right, and now it's 10 milligrams per ml. If I have 0.25% bupivacaine for surgery. I move that one spot over to the right. What does that mean? 2.5 milligrams per ml of bupivacaine, right? So if you ever see that concentration, that's what we're talking about there. D50 stands for dextrose 50%. That means you move it one over to the right, you have 500 milligrams per ml of dextrose, a half a gram of dextrose per ml, right? The little things like that are handy tips. So when you're looking at drug concentration, you can figure out what dose you're giving to your patient based off the volume there, okay? Any questions for that? Be able to do like a drug dosing calculation in terms of, I tell you, a patient's getting ceftonir, 14 milligrams per kilogram divided twice daily. It comes in this concentration. How many mLs are they getting per dose, right? Make sure you're looking at things like if it's divided daily, if it's divided twice a day, if it's milligrams per kilogram per day or milligrams per kilogram per dose. Be very particular about when you're reading that to make sure you're getting exactly what I'm asking for in the test, okay? You should have no problem with that. You've been doing it since the summer, so it should be easy peasy, right? Easy 2 points. Or maybe I'll do more. Maybe it'll be 4 points or 40 points. I don't know. We'll see. I'm just kidding. All right, so geriatric. So this section, hopefully we'll see what I can cover here. And I'll determine where the test material will end. Essentially, though, we are an aging population. The boomers are getting older and older every day. And guess what? They're going to be the bulk of a lot of your patients if you're working with adults, as it turns out. It's really important to make sure you're doing good assessments on these patients in terms of figuring out like what medications they're taking, what they're not, how they take it, all these things here, because you're going to find that it gets more complicated as you go on. It's not uncommon to have patients have diabetes, hypertension, CHF, COPD, all these things together, and guess what? They get 2 or 3 meds for every one of those disease states. It adds up quite quickly. Patients will have multiple drugs from the same class, and they say, well, which one of these do you take? And they're like, I think I take that one. What about these other ones? Oh, they told me to stop that years ago. And you're just like, well, why do you still have them? You never know, right? So you'll find some difficulties with that. You guys ever heard of like a brown bag event? We used to do this in pharmacy school where you'd go to the nursing home and we say, okay, bring out all your brown bag, your little brown bag of all your medications there. And we'd go through and be like, okay, this one expired back in the 80s. And this one you haven't taken for 6 years, so we're going to throw that away. And it was incredible how much you could shore down their medication list by looking at all the stuff they have in their bag, right? Because again, they hoard stuff in a lot of cases there. And again, bringing together the whole team, right? Look at your dietitians, look at your respiratory therapists, look at all your different teammates in order to help you out, in order to get a full assessment there. In terms of activity, you also want to look at changes over time as well. So again, if I add on a medication, say for instance, say I start a medication for rheumatoid arthritis, right? Is their functioning getting better? Can they do things that they couldn't do before because of their arthritis, or is it getting worse as time goes on? Maybe I, put them on to a benzodiazepine, and all of a sudden they sleep for like 14 hours a day and they don't get around and do stuff like they used to. So things like that you want to be looking at, not only just the basics, but also more things like, can they get out and go shopping for themselves, or can they do some of those more kind of advanced sort of functioning activities there. In terms of nutrition, this becomes an important one. So like dentition can be really a problem here for these patients. What do you think it does in terms of their nutrient intake? It may suffer in a lot of cases there, right? So again, if they are not getting enough protein, their muscle stores can go down. You'll find that can affect how drugs will be distributed. You'll find that maybe they're trying to consume more calcium, right? Because they're worried about osteoporosis. That can cause drug interactions. So these are all things you want to kind of get a feel for in terms of how that's going to be affecting the medications that we're using for those patients there. Also, consider things like lack of financial resources in order to actually get access to a lot of these things like food or medications. I always hate watching those videos, like news stories where they're talking about kind of run-of-the-mill people, and they're like, yeah, I had to choose between getting food or I had to choose between my medications, and so I opted to get food because I need to eat to survive. I can go without my hypertension medications for a month, right? It's kind of sad when I have to make those choices, but that's kind of where they're at in a lot of situations. Think about things like what they've consumed in the last 24 hours in terms of like how much fluid intake they have in terms of water, alcohol, what kind of foods they're taking in. Are they getting any fiber? This can all be playing a big role. I'll tell you, I had a distant family member just recently. They have long-term smoker, long-term drinker. She's postmenopausal. She's probably in like her mid to late 60s. And she is on chronic pain meds. She has a lot of pain issues that she has, so she's taking chronic opioids, right? So opioids are going to do what to your GI tract? Slows it down, right? So now all of a sudden she has like a lot of abdominal pain, discomfort, and things like that. So she calls us up, me and my wife, because is there anything I can take to help me out with this? I'm having all these abdominal cramps. Is there anything like, can I get like a Bentyl, or can I get like a, they were looking for like an anticholinergic basically to help out with the spasming of the abdominal tract. And so we were asking some questions, and we're like, well, wait a second. Well, when's the last time you had to poop? And she's like, oh, it's probably been like a week. We're like, excuse me, what? Like, because of the chronic meds that she's on, she maybe has a bowel movement every 2 to 3 weeks, she says. So perhaps that is what's causing a lot of the abdominal cramping that she's experiencing, right? Also consider, what would an anticholinergic do for that? It would worsen that, right? So now all of a sudden she's going to be even more backed up because of that. So we're like, well, pump the brakes here. Let's not add on a medication just to fix that. Let's fix the constipation issue first. Not only that, but how do you think her nutrition intake is? It's not great, right? So she has electrolyte disturbances. So guess what happened? She was sitting on the couch. She developed a Charlie horse, probably because her potassium or magnesium was off. She stands up, and guess what happens? Has a fall. Now she's postmenopausal. She's osteoporosis. She ends up fracturing her wrist, and she ended up getting like an L4 fracture. Not great, right? So she ended up getting out of the hospital, and then, now they determined she has to go back for surgery. But you can see how all these different disease states kind of compound on one another and can lead to some big issues. And so when they come up and they say, oh, my stomach hurts, can you give me something for that? You need to dig deeper to figure out what the heck is actually going on here, because adding on medications to kind of willy-nilly is just going to make things worse in some situations. So little things to consider there. Again, with alcohol intake, you'll find that some older patients, like this is their primary source of calories that they're getting, which can lead to all kinds of issues. You can get things like hyponatremia, it's called beer potomania they can develop if they only drink alcohol. Like beer, it has very low sodium content, for instance. So little things like that to kind of look at their weight, how it's been changing over time, if they're kind of gaining or losing, all these things you want to look for. In terms of laboratory assessments, these all can be really helpful here in determining sort of how well they should be processing these medications, but certainly you can look at things like their A1C. What does that help us out with? Yeah, their diabetes. What does A1C tell us? Yeah, their average blood sugar levels over the past, what time frame? 3 months or so, right? That can tell us, like, are they being compliant with their medications? You have diabetic patients. We'll talk about diabetes, I think, coming up a little bit later on. You have diabetic patients who will not be taking their insulin like they should, not be taking their metformin like they should, and then right before they come and see you, or before they come and get their labs, all of a sudden, I'm going to be compliant now and make sure I'm not eating any sugar, and they'll use their insulin. So when you do their fasting blood sugar, it looks okay, but then guess what? You check their A1C, what does it look like? Through the roof, right? So you can look for things like that to see, are they being compliant with the regimens you're prescribing for them? Look at things like liver function, look at things like their LFTs, look at their renal function to make sure that they are actually going to be able to process these meds as they should be. A lot of things that I would see in the ER when you have patients coming in from the nursing home is that they would have long-standing kidney disease that no one was really addressing and adjusting their doses as time went on. I had one patient who had COPD that had been on theophylline for probably like 20, 30 years. She was like, I think 80, close to 90 years old. She'd been on it for so long, but no one had gone back and readjusted her dose based off renal function, and guess what? Comes in with a really high level with seizing and actually end up dying from that, right? So again, you gotta be watching these over time and make sure someone's addressing it. Because you may be that central person that's kind of the one kind of bulwark against all these different issues happening, and when they're seeing a neurologist and their pain management doc and their GI doc and all that, you may be that one central person can help bring it all together. So you see a lot of polypharmacy. A lot of that's because these patients are also living for longer, so they're having more disease states kind of adding up, and that means more medications are going to be treated with, right? And guidelines will come up and they'll say, okay, let's add on this medication, and you can see how it can kind of spiral out of control after a short period of time. You can have someone with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, COPD, and all of a sudden they're like on 12 medications about 5 times a day. Like, I can barely take a multivitamin 1 time a day. I can imagine being an elderly patient trying to do all of this, right? I had one patient who had come up to the pharmacy counter. I was on rotations at the time, and she could not see anything farther than 2 inches in front of her face. Basically, her vision was so poor, and she's filling probably 12, 15 medications all at the same time, coming in for her refills. And so when I was looking at the pill bottle, she's like asking me to change the caps out from her old bottles onto the new bottles. And I looked at the caps, and they all had like a certain shape or a color on them. So for instance, that was like a red triangle. One was like a black dot. And so I was like, is this how you keep track of it? Because she couldn't read the labels, right? And she's like, yeah, it's how I know all my medications based off the shape and the color. And I said, so you remember all of these? And she's like, yeah, I got it down. So I was like, okay, so I quizzed her, and sure enough, she knew every single one of those medications based off the color and the shape on the top of the bottle, right? So I had to make sure I put them on the right ones, otherwise she'd be really getting screwed up. So anyway, so they still may be with it mentally, but physically they may have those impairments. Again, if we're not conscious of this, we can cause a lot of adverse drug reactions. We'll frequently see that falls is a really big concern here, right? And it's not just your sedative medications, but it's your blood pressure medications, could be antipsychotics, could be all these different things that could be causing risk for falls, right? And so again, when they fall, what happens? They break something, right? And so that, again, can be very disabling for those patients there, and it can definitely hasten their mortality for sure. Also, compliance is going to go down as well, either due to not remembering, or maybe they just don't want to take all these meds. There's a lot of reasons why they may not be compliant there. And so some things we can do is make sure that we are trying to narrow things down and keep it as simple as possible. So if we can use combination medications, that's very helpful. We can make sure that they can have, say for instance, they have memory impairment, and we can put them on a patch. They don't have to change that every week, right? They may help with the compliance in those cases, or provide things like memory aids for them as well. Also think about things like, depending on how frequently they're seen in the healthcare setting, they may have a really hard time getting IV access in a lot of cases, because a lot of the veins got a lot of scar tissue, may be difficult for them to actually get access for them. And just think about, do they even want treatment at this point? By the time they're 95 years old, they're like, I don't really need to have any more meds added on. I'm good to go whenever, right? From a mortality standpoint. So it's like, they may not want to adhere to that treatment, even though you may say, this is going to be the best drug ever for you, it's going to extend your life. They're like, I'm good. So you have to kind of think about if you're moving into more of that palliative care sort of standpoint there, where you're saying, okay, well, let's just make them more comfortable, increase the quality of their life versus just the quantity as time goes on. And so you'll see that there, whereas as time goes on, as the disease progression happens, and you'll find patients that, depending on what their sort of prior directives are, they may say, hey, I don't want medications. If I go into a code, cardiac arrest, don't give me any meds, or don't intubate me, or don't do these things here, based on the fact that they just want certain life-saving measures, or maybe none at all, as the case may be, right? So what kind of changes are we going to see in these patients? We're going to definitely see, in terms of cardiac function, what's going to happen to them. Like blood pressure typically probably goes up, right? You may find things like, ejection fraction is going to go down as the heart kind of gets worn out over time. Especially if they have hypertension, it's going to impede sort of ventricular function. In terms of renal function, what's going to happen? It's going to decline, right? So everything kind of starts failing. I feel like after I turned 30, like everything just started like failing on me. I'm like, ow, this thing hurts now. I'm like, no, that's just normal. I didn't do anything to it. It's just me breaking down. But things like, GFR, cardiac index, breathing capacity, all that's going to be declining as time goes on. And so you need to make sure that even if you start a medication here when they're, say, 50, you need to readdress that when they turn 60 and 70 and make sure that you are using an appropriate dose based on that change in function. So in terms of GI effects, you're not going to see a ton of issues here, but there's a lot of drug interactions that happen. Constipation is a really big issue for a lot of these patients here, which can impair their ability to eat effectively, can cause a really big decrease in their quality of life. So for instance, you'd have my wife, when she did her residency in pain management, she did it at the VA in Gainesville. And so a lot of those old vets, they're really kind of curmudgeonly types, but you go in there like, how's your pain? And they'd be like, I don't know, it's an 8 out of 10. It's okay. And so you try to adjust all their medications, come back like, it's still an 8 out of 10. Well, they're like, okay, well, how's your stomach doing? They're like, I'm always cramping, it always feels bad. Well, all of a sudden, if you get their bowel regimens under control and they actually have a good bowel movement, all of a sudden you come back and you're like, hey, how you doing? It's like, I feel much better. It's like a 4 out of 10, and my vital signs are actually like improving and all these different things. So really never underestimate the value of having a good bowel regimen for these elderly patients. They definitely need it. Make sure they're getting their fiber in. Make sure the medications are not going to be kind of worsening that. Calcium channel blockers, opioids, anticholinergics, all these things can exacerbate that. Shouldn't really see too many changes in terms of actual absorption of medications for these patients here, but you may find things like impaired gastric emptying in like your diabetic patients because they have gastroparesis. You may find that depending on their dietary changes, maybe they're not eating as much fiber anymore, maybe they are having more OTC meds coming in, things like that. It can make some big changes there in terms of their medications. I know when I was doing my, I had a community rotation that I did as my first rotation in school, and it was at a Coumadin clinic, right? So it was a warfarin clinic, and it was in Palatka, Florida. And so guess what a lot of patients there eat for their food? Whatever they grow in the backyard, right? So a lot of times it's collard greens and spinach and kale, and guess what that has a lot of? Vitamin K, right? So I had to make sure we were adjusting our dosing based off the fact that, yeah, these are salt of the earth kind of people. They grow a lot of their own food. This is how they get most of their food. Yeah, we got to make sure we adjust for that sort of thing there, right? So other issues you're going to find, especially when you're looking at things like distribution, typically muscle mass will go down Adipose tissue will typically go up, and they have overall reduced body water. So you may find things like lipophilic medications have now a larger volume of distribution distribute to. Hydrophilic medication may have a smaller volume of distribution depending on the situation there. So those are pretty common changes you'll find. Even things like albumin may go down over time, especially as nutrition suffers. If they have albumin levels go down and they had a drug that was highly bound to it, what do you think would happen to the volume of distribution? It would end up increasing, right? So serum levels will go down because more of it's distributing out to the tissue because there's no albumin to hold on to it there in the bloodstream. So things like that can make some differences. And so that free fraction, this is really important for like phenytoin for those elderly patients, because as they get lower albumin levels, they have a higher free fraction of phenytoin. That can lead to a lot of sedation. And what else could occur because of phenytoin? What did you say? Well, that's with IV administration, which is always a concern, but more talking about like the ataxia they can develop and then falls, right? So that's another big really risk for those patients there. It could be related to their albumin levels, for instance. So typically drug clearance is going to go down. Be cautious, especially when you're evaluating patients, elderly patients for their renal function, because you may find things like muscle mass going down will also lead them to have decreased serum creatinine levels. So for instance, if I have an 80-year-old lady who weighs all of like 100 pounds, and I see that her creatinine is like 0.6, that may look good for an adult patient, like a typical adult patient, but that may be falsely low for her because she just has no muscle mass left to actually produce that creatinine. So oftentimes if I have like a really elderly patient that has a creatinine less than 1, I'll go ahead and bump it up to 1 for my dosing calculations just to make sure I'm not too aggressive with them, right? Because you typically can give more drugs if you need to, but I don't want to be too aggressive. What if they have an amputation? What is that going to do? They have less muscle to make less creatinine, so it's going to falsely drive it up or down? Down, right? Because they have less muscle to produce creatinine. And so even though their kidneys may not be functioning all that well, it'll look like their kidneys are performing better than what they are. So who might have an amputation? Diabetic patient. Guess what diabetics also have an issue with? Their kidneys, right? Because they get diabetic nephropathy. So if you have someone who had a, say, below the knee amputation, and their kidneys aren't that great, you may overestimate what their renal function really is because you say, oh, it looks okay, but just because they don't have enough muscle mass to actually produce all that creatinine. So little things you have to think about. As patients get more and more complex, the older they get, and the more issues they develop. Hydration status is also another really big one as well. You'll find a lot of these patients, especially in nursing homes, when they get sick, they don't have good PO intake, no one's really checking on them, and so they can come in quite dehydrated, and so that can also affect, you may think you're, maybe the creatinine clearance is lower than what you expect it would be, but once you hydrate them up a little bit, then it appears to look better. And so just be aware, and again, think about how these different factors are going to affect this. So this is a Cockcroft-Gault equation. I'm not going to have you calculate anything from this on the test. I want you to know how these different features or different variables factor in. So for instance, the older the patient gets, what is that going to do to their creatinine clearance? It's going to get lower because this product here is going to get smaller and smaller, right, as the patient gets older. So that's going to decrease creatinine clearance. That makes sense. Older patients, worse kidney function, it's going to go down. How about their weight? Typically it's going to increase it, right? Because again, they have more muscle mass, so it should increase the creatinine. So we typically see there's a directly proportional relationship there. But the other important feature here is the fact that the creatinine is down in the denominator. So as creatinine goes up, what does that do to your creatinine clearance? It's going to drive it down, right? So that makes sense too. More creatinine means you're not clearing it as well. It means you have lower kidney function, right? So those are things I want you to kind of keep in mind, how those variables are going to be playing a role. Remember, why do we multiply by 0.85 for female patients? Yeah, and on average, they have less muscle mass than male patients, and so that's why we adjust it for that. But again, there's a lot of different equations that are out there. So for instance, like you might run into something like an MDRD equation, and this was modeled such that they actually factored in if the patient was black or not, right? That had a feature or played a role in determining how well this model could predict creatinine clearance in GFR. So be aware of what calculation you're using in terms of what you're using for your drug dosing. So overall clearance should be going down. You can find decreases in bioavailability. You can find decreases in first pass metabolism. That can all be playing a role here as well, causing levels to maybe go too high. If you have poor functioning of like your phase 1 or phase 2 interactions, remember too that they're more likely to have drug interactions affecting things like CYP induction or CYP inhibition, and that will also play a very significant role as well. Think about things like if they have CHF and maybe they're pretty backed up from a vascular standpoint and they don't have as much liver blood flow. What does that do to metabolism? If I'm not carrying the drug in the blood to the liver, can it get metabolized? Nope. So it sticks around for longer, right? So for instance, like if I had a patient who was on a lidocaine drip, I'd have to give them a lower rate because it's cleared through the liver. And if they have CHF, they're not going to be able to have as much throughput through the liver. So I have to give them a lower dose. Otherwise, they can develop toxicity. So, and again, you think, are patients that are geriatric, are they just more sensitive? Well, it has more to do a lot with the kinetics, right? They have a lot less hemodynamic reserve, a lot less homeostatic reserve than, say, a younger patient might. And so because of that, you can see things that if I drop blood pressure in an elderly patient, it's going to be more significant in terms of things like orthostatic hypotension, causing falls and things like that than it would be for a younger patient, right? So these are things you want to consider as well. So, do you guys have anything after me? Yes? Like right at 10? Well, I'm going to go right to 10 because we're delayed because of this. So I'm going to see what I can cover here. So just real briefly, we kind of alluded to a lot of these already, but you got to be really careful. And have you ever heard of the Beers list? The Beers list, it's not what you get at the pub, right? So the Beers list is a list of medications that you want to be really cautious with using in elderly patients because they're very likely to either cause changes in their blood pressure, changes in their mentation, they can worsen dementia, all these things that are potentially really dangerous. So I want you to consider, be cautious in using these medications. That means you can't use them, it just means be more cautious, or maybe select certain agents over others. And so for instance, using things like sedative hypnotic agents like benzodiazepines in elderly patients can be really problematic. So for instance, if they have say a longer half-life because they can't clear it as well through the liver, well, that means the drug's going to be sticking around for longer, they're going to have higher levels, and they may be more at risk for things like falls. Things like opioids, you may have even higher rates of respiratory depression, especially when you're combining it with something like Xanax, right? If you're combining benzos plus opioids, you know, there's a lot of synergism there. Very frequently, you'll see in the ER, I always talk about oxysomanex, where it's oxycodone, soma, which is a muscle relaxant, and then Xanax. It's a very common trifecta of people who overdose come in either intentionally or unintentionally, as the case may be. But think about things like lithium, right? As liver or kidney function goes down, what happens to lithium clearance? It's going to go down as well, so they can hold on to more of that, right? And you're going to see more interactions with things like diuretics and whatnot. Antidepressants can also be issues as well. So imagine if you put an elderly patient on an anticholinergic like a TCA. That's going to be problematic because that can cause a lot of changes in their mentation. If you recall, what was the mnemonic we used for our anticholinergic effects? What was the Mad as a Hatter, right? It can cause mental status changes in them. So you want to avoid anticholinergics. So to get around that, we use things like SSRIs now. So in some cases, we have safer drug classes that we can use. In some cases, we're still stuck kind of using not great drugs. Obviously, with antihypertensives, you're more at risk for orthostatic hypotension and falls. With antiarrhythmics, you have to think about what's their electrolyte status as well, because we know that by changing their potassium, their magnesium, sodium even, that can predispose them to arrhythmias potentially. So you want to be cautious with that. And so, again, as the number of drugs increases, we know there's going to be an increase in the number of adverse drug reactions they're experiencing. And again, if you think about it, a lot of times they don't even know what a drug interaction is or what an adverse drug reaction is unless you tell them what it is. Sometimes they just think, oh, this is just the new normal now. This is, they don't know it's related to a med. So you want to make sure they know that. And then always, always, always have them be candid with you about their OTC and herbal medication use, right? Did I ever tell you about the lady who's taking ginkgo for her memory? So they had this elderly lady, she showed up in the ER. She was having stroke-like symptoms. Probably 80, 85 or so. Coming in, she had a history of Alzheimer's and AFib. So for the AFib, what do you think she was taking? It was back before we had our NOACs, like rivaroxaban and stuff like that. So she was taking warfarin, right? And then she was trying to, for her memory, she wanted to take an over-the-counter meds or a herbal supplement. So she took ginkgo biloba. Well, ginkgo biloba also has some effects to cause platelet inhibition and can increase the risk for bleeding. So what do you think happened to that patient with the stroke-like symptoms? She had a massive head bleed because of that interaction there that she was unaware of, and she maybe had not cleared it with her healthcare providers, or maybe they didn't look it up, and now that patient was dead, right? Basically because they could not get any function back from her. So point being is you want to have an open, honest conversation with them. Don't be like, don't take those herbals, they don't work, because they do stuff. You want your patients to feel like they can come and talk to you about it, right? Be aware as a prescriber, you may be that central hub, kind of coordinate between all these different providers. And I'll tell you what happens is that, I'll have providers, or patients will be on a whole list of medications, maybe have 3 or 4 different providers all ordering them. And I'll say, hey, this patient has a drug interaction. Do you want me to go ahead and stop this medication? They'll be like, well, the GI doc wrote for that. Do you have to talk to them. Or the neuro doc wrote for that, you have to talk to them. And so I go try to talk to them. It's like, well, okay, well, can we do something about this? Or, well, I'm not the primary doc. I don't want to do anything for that. So all of a sudden, everyone's trying to take the hands-off approach to it. And it's like, okay, well, the patient still has a drug interaction. We still need to do something about this, but no one wants to take responsibility. So what are you going to do as super awesome PAs? You're going to take responsibility and be like, nope, we need to do something about this and cut this medication out or change the dose or whatever the interaction is at this point here. So you want to make sure that's kind of your role and responsibility. And a lot of times patients may not even know what meds are meds, right? So have you ever heard of BC powders or Goodies powders? Right, that's a very common thing. They're actually aspirin. A lot of patients don't know they're aspirin. They just say, oh, just take it whenever I have a headache. And they can get aspirin toxicity pretty easily because they don't realize that they're taking so many of them. So overall, and I think this is kind of towards the end here, but make sure you're asking all the right questions. Make sure you're being really thorough, especially if the first encounter with an elderly patient, to get an idea. Remember, how do you make sure that if you're educating on something, you're telling them how to take a medication, that they understand how to take it? Teach back method, right? So have them say, okay, well, I just told you how to take it. How are you going to take it? I told you to take 2 tabs twice a day. What does that mean to you? And they can say, okay, well, I take 1 tab in the morning, 1 tab at night. And you're like, no, that's not right. Take 2 tabs in the morning, 2 tabs at night, right? So those are things you can catch as points there. Again, think about things like, are they getting medications from outside sources? Are they going, say, south of the border, or maybe going to Canada for medications because they're cheaper? That may be playing a role. Are they getting things from family members or friends? Do elderly patients ever share meds? All the time. They're like, oh yeah, I had a UTI last week. Here you go. You can have the rest of my Cipro I kept left over. They do it, right? They're very cost conscious in a lot of cases there. Ask about things like, do they forget to take medications? What do they do when they forget? I've had patients that have forgotten to take, say, methotrexate for their rheumatoid arthritis, and then they end up doubling up on doses, which is not appropriate, right? Sometimes you want to double the dose to catch up. Sometimes you want to skip them all together. And so you want to ask what they do in those situations there. We have a lot of helpful things to help with this, especially as patients get older. Maybe they are more technologically advanced and may have access to cell phones and things like that can help them to remember to take their meds. Anything that works, right? I always like the mantra, if it's stupid and it works, it's not stupid, right? So whatever helps them out, just like that lady with all the shapes on the top of the bottles there. Make sure that, if you can, try to help to encourage cost reductions for these patients. Most of them are on fixed incomes. So things like, what's the free list at Publix? What's the cheap list at Walmart? Help them out, right? And again, think about this intelligent non-compliance. Like maybe they are taking things not like they should because of maybe they can't afford it, or maybe because they have a side effect. Make sure they're kind of being candid with you and letting you know when that kind of stuff's happening. So I know it's kind of a whirlwind in the feature there, but I feel like we kind of talk about geriatrics all the way throughout. We're always kind of talking about elderly patients, with all these other things. But do you guys have any questions at all for the test? So the test will cover through migraines, right? For the last test, up through the end of this. Let me see if there's any questions on the board. Okay, good. Nothing upside down. Oh, there is one upside down. Oh no. How can I change it? Oh my god, I don't even know how to use. Oh, there we go. Perfect. Oh wait, that's the same one. Never mind. Get out of there. Can you provide examples of calculations expected in regards to peds? So just like I mentioned before, if I say, let's do ciprofloxacin, 10 milligrams per kilo, Q12 hours, and a 23 kilo kid. Should be able to figure that out, right? It's the same no matter what. Yes, ma'am.
So can we go back and look at the PowerPoint from last summer?
100%, right? You can go back and look at your old prescription assignments and be able to practice with that, right? You can make up, I would make up questions and give them to your fellow classmates, and they can do the same to you to get that extra practice, right? Just make sure you come up with the same numbers there. What's a good resource to check on drug interaction between herbal supplements, OTC, and prescribed drugs? That's going to be hard to say. It depends on where you work and what resources are available to you. Most drug references will have something available like an interaction checker. So for instance, if you have Lexicomp available to you, there's a whole interaction checker. I can actually show you real briefly if you guys don't mind. So for instance, I have a login from Nemours. I can do interactions. I can look at something like warfarin, something I can spell. And then I can do something like ginkgo. I think it should come up here. Maybe not. It should be. Well, somewhere. I obviously don't have to look it up that often, but there are references that are out there that will be able to show you the interactions between those, or something like an OTC med. You can certainly put something like that in. So if I did like cimetidine, I could pop that in and get an analyzing and see if there's any interactions. Usually, again, kind of like what we talked about with, for instance, like, pregnancy categories, or we will talk about that. There's like A, B, C, D, and X. Same thing kind of goes for this. If you see like a D rating, this is like, that's probably something you want to consider switching out, or like an X means never mix them together. But it depends on where you work and what you'll have access to, essentially. Okay. Any other questions? All right, if not, I'll see you guys next week. But make sure you send me any questions earlier than later if you can.